Okay, let's unpack this. We are diving deep today.
We are.
We're really getting into mastering the pharmacology, the toolkit needed for managing something incredibly complex.
One of the most delicate balancing acts in medicine, really, intentionally managing the immune system.
Exactly. And our source material, it's like a professional roadmap, isn't it? For understanding these immunosuppressants.
Absolutely.
These drugs are critical, used for organ transplants, sure, but also for those really tough autoimmune diseases.
And this isn't just, learning a list of drug names. That's not the point.
No.
The goal here for you listening is genuine mastery. It's about understanding not just what they are, but the molecular dance they interrupt.
The choreography, I like that.
Yeah, we need to break down exactly how they manipulate these very intricate T-cell signaling pathways.
To stop the body damaging itself, or in the case of transplant, rejecting that new organ.
That fundamental knowledge, that's the foundation for prescribing these things strategically. You have to know the how.
So our mission today, essentially, is to get the why and how of using multiple drugs together combination therapy. Why that three-signal model for T cells is so fundamental.
It dictates everything.
And maybe the most critical part, navigating those constant high-stakes trade-offs. You know, the power of the drug versus its toxicity. Clinicians face that every single day.
Every patient, every dose. It's a constant calculation.
Okay, so before we can even talk about turning the immune system down or off.
You have to know what you're turning off.
Exactly.
Yeah.
We need to really grasp the cascade we're actually targeting.
Right.
And for all practical purposes, particularly thinking about transplant rejection, this whole T-cell activation process, it's really governed by one core idea, the three-signal model.
The three-signal paradigm, yeah. That's the blueprint. It's absolutely foundational for understanding how these drugs work.
So it all comes back to T cells.
T cells are central players, definitely. The key figures in cell-mediated immunity. And their activation, it's deliberately complex. It's not a simple on switch.
Needs layers of confirmation.
Precisely. It requires three distinct signals, three molecular conformations, before that T cell really commits to, proliferating and mounting a full-scale attack.
And the drugs target these signals.
Almost all the major ones, yes. They're designed to essentially disable one of those three gates. So let's start at the beginning. Signal 1, recognition. This is the trigger.
The first handshake.
Kind of. It happens when the T-cell receptor, the TCR complex, specifically a structure called CD3, when it recognizes and binds to an antigen.
Okay.
And that antigen isn't just floating around, it's presented, it's shown by a specialized cell, an antigen-presenting cell, or APC.
Like a macrophage or dendritic cell.
Exactly. And the antigen sits within that MHC molecule, the major histocompatibility complex. So the APC basically shows the T cell this foreign piece, like you said, the wanted poster.
But here's the key part you mentioned earlier.
Right. Critically, if only signal 1 happens, the T cell does not activate.
It doesn't go.
No. It's necessary, absolutely, but it's not sufficient. It sort of generates the potential, the readiness, but nothing more happens without the next step.
So the body senses something foreign, maybe a protein for that new kidney, but needs like a second security check. Confirmations, this is really a threat.
That's signal 2, co-stimulation. And this is, pharmacologically, maybe the most crucial step we target.
The green light.
The green light, exactly. It involves a completely separate second interaction between the APC and the T cell.
Different molecules involved.
Different molecules. Proteins on the APC surface, specifically CD80 and CD86, you might also hear them called B7.1 and B7.2. They must engage with the CD28 receptor on the T cell.
Okay, so two distinct binding events needed.
Yes. And here's something really important. If signal 1 happens without signal 2, without that co-stimulation,
What then?
the T cell actually enters a state called anergy. It becomes permanently unresponsive, essentially turned off to that specific antigen.
Wow, so it learns to ignore it?
In a way, yes. Signal 2 is the immune system's built-in safeguard. It ensures a big response only happens when you have both recognition and a sort of high-level danger confirmation.
Which makes blocking signal 2 a very attractive target.
Extremely attractive. It's a highly targeted way to try and induce tolerance to stop the attack before it really gets going.
All right, so we've got the double confirmation, signal 1 recognition, signal 2 permission. Now the T cell is ready to act.
Now its internal machinery kicks into high gear. This leads to the final result, which is exponential. That's signal 3, proliferation. Amplification.
Making more T cells.
Lots more. Signals 1 and 2 together, they activate a whole cascade of complex intracellular signaling pathways.
Inside the cell net.
Inside the cell. One of the most important is the calcium-calcineurin pathway, and we'll come back to that in detail with the CNIs.
Okay.
This pathway activation leads directly to the cell making key signaling molecules. Cytokines.
Chemical messenger.
Exactly. And the dominant one here, the really key one, is interleukin-2. IL-2.
The T cell growth factor.
That's exactly what it is. Once a T cell makes and secretes IL-2, it acts on itself, that's autocrine, or on its neighbors, paracrine. It binds to a specific receptor on the T cell surface, the high-affinity IL-2 receptor, which is also known as CD25.
And that binding event.
That binding event is signal 3. It activates the cellular machinery that controls the cell cycle.
Like telling the cell to divide.
Precisely. It does this primarily through a protein called the mammalian target of rapamycin, or mTOR.
Another key target for drug?
Another key target, yes. Activation of mTOR basically pushes the T cell from its resting phase, G1, into the DNA synthesis phase, S phase. And that leads to rapid, massive T cell proliferation, clonal expansion.
And that's the army we're trying to stop in transplant rejection.
That's the army. That massive expansion is the core of the acute immune response we're trying desperately to block.
It's fascinating how when you lay it out like that, the whole pharmacopoeia, all the major drug classes, they really do just slot into blocking one of these three signals.
It provides a very clear framework.
Yeah, you've got the CNIs dealing with the fallout of signal 1.
By blocking calcineurin, yeah.
Then belatacept hitting signal 2 directly.
The co-stimulation block.
And then the mTOR inhibitors and drugs like basilicimab targeting signal 3, the proliferation signal.
Right, hitting IL-2 signaling, or the downstream mTOR pathway. It maps very neatly.
Okay, understanding the target signals, that's crucial. But it's only half the story, isn't it?
Right, the timing is just as critical. The pharmacological strategy isn't static. It's divided into two very distinct phases.
Induction and maintenance.
Exactly. And each requires a different approach, different intensity, different drugs sometimes.
So induction is the immediate hit.
Induction therapy, yeah. That's the initial, usually highly potent acute intervention. It's used right around the time of the transplant surgery itself.
Big guns, basically.
Often, yes. These are powerful immunosuppressants, typically antibodies, monoclonal or polyclonal. They're designed for a massive, often non-specific immune system knockdown right at the start.
Why so strong right away?
The goal is to eliminate or severely suppress that initial rush of T cells that are going to immediately recognize the new organ, the allograft, as foreign. You want to prevent that very early, hyperacute or acute rejection.
Give the organ a chance to settle in.
Exactly. Ensure it can start functioning without being immediately attacked. It's a huge but temporary immunosuppressive strike.
And then after that initial shock and awe campaign.
Then you shift gears, you move to the sustained long-term approach.
Which is maintenance therapy.
That's the long game. These drugs have a different job. They need to provide adequate protection for years, potentially decades.
While being safer long-term.
Right. They have to carry a much lower risk of cumulative side effects, especially infections and malignancies, compared to those potent induction agents.
And this is where the combinations come in.
This is the core principle of modern maintenance. Combination therapy. The standard protocol involves using 2, 3, sometimes even 4 different agents together.
Let's focus on that combination idea for a second. Because, someone might ask, if you have a powerful drug like tacrolimus, why not just use a really high dose of that one drug?
It seems logical, but it doesn't work that way in practice.
Why not?
Because the therapeutic window for these drugs, the gap between an effective dose and a toxic dose, is incredibly narrow.
Right.
And the specific side effects, which are often dose-dependent, become just too severe, too damaging if you try to achieve full suppression with just one agent at a high dose.
So you combine them to spread the risk.
Exactly. By combining drugs that hit different points in that T cell cascade we just discussed, signal 1, signal 2, signal 3, general proliferation, you get a synergistic effect on the immune system.
More bang for your buck, immunologically speaking.
You maximize the protection, but crucially, you keep the individual doses of each drug lower.
Minimizing the toxicity of each one.
Precisely. Especially minimizing those really problematic long-term effects like kidney damage, cardiovascular issues, diabetes.
And this principle also tells you what not to do. You absolutely should not combine drugs that work the same way if they share the same major toxicity.
That's a fundamental rule.
The classic example being tacrolimus and cyclosporine together.
The textbook example. They are both calcineurin inhibitors, CNIs. They hit the exact same target downstream, inhibiting calcineurin, stopping NF8 translocation.
So no added benefit.
Zero synergistic immune benefit beyond what a higher dose of just one could give you. But what you do get is a dangerous doubling down on their main shared limitation: severe nephrotoxicity, kidney damage.
Which is often the very thing you're trying to prevent, especially in a kidney transplant.
Exactly. So that combination is just universally avoided. It's counterproductive and harmful.
This strategic thinking even applies within the induction phase, right? You mentioned using either basiliximab or ATGM. They're both for induction, but used very differently.
Absolutely. The choice there depends entirely on the patient's immunological risk profile.
High risk versus low risk.
Essentially, yes. Basiliximab, remember, it's that targeted IL-2 receptor blocker. It hits signal 3. But importantly, it's non-depleting. It doesn't kill T cells.
So it's gentler.
Much gentler. It's generally very well tolerated, doesn't need pre-medication. We often use it in patients considered low immunological risk. Or strategically, it can be part of protocols trying to avoid steroids altogether, or to allow us to delay starting the nephrotoxic CNIs, or start them at a lower dose. It's a nudge, not a hammer.
Okay, and the hammer.
The hammer is antithymocyte globulin, ATGM, or thymoglobulin. That's a potent lymphocyte-depleting antibody. It wipes out T cells.
You save that for tougher situations.
Exactly. It's reserved for patients at high immunological risk. Maybe they've had previous transplants, or they have high levels of preformed antibodies. Or it's used to treat severe acute rejection that's already established. You wouldn't use the sledgehammer, ATGM, if the feather, basiliximab, is likely to be enough.
Okay, let's move deeper into these heavy hitters then. The antibodies and other targeted agents used right at the beginning for induction or when things go wrong for treating active rejection.
Right. These are absolutely fundamental for prolonging the life of the allograft. Remember, an allograft is tissue from someone who isn't genetically identical.
So the immune system is primed to attack it.
Inherently, yes. Antibodies are probably the most powerful tools we have to prevent or reverse that.
And you mentioned the naming convention can give clues.
Yeah, it's helpful shorthand. If a drug name ends in UNAB, it's a monoclonal antibody derived from a single cell line. Very specific.
Okay.
If the name has XI in it, like rituximab or basiliximab, it's chimeric, part mouse, part human protein. If it has a SU, like alemtuzumab, it's humanized, mostly human.
Does that matter clinically?
It can. Generally, the more human the antibody, the less likely your own immune system is to mount a reaction against the drug itself, which can sometimes happen with chimeric antibodies over time. So let's start with the broad, nonspecific powerhouse. Polyclonal antibodies, the antithymocyte globulins, ATGM, thymoglobulin.
These aren't monoclonal.
No, they're polyclonal, meaning they're a complex mixture of many different antibodies. They're produced by immunizing animals, usually rabbits these days, sometimes horses, previously with human thymocytes, which are immature T cells.
Why rabbits now?
The rabbit preparations, like thymoglobulin, are generally considered more potent and might have a slightly better side effect profile compared to the older horse-derived ATGM, though both are still used.
And what makes them so potent? How do they actually work?
Their mechanism is pretty broad and, frankly, destructive to T cells. They cause profound depletion of T cells circulating in the blood, mainly through complement-mediated lysis, basically punching holes in the cells. And they also trigger apoptosis, programmed cell death, in T cells that are already activated. So they essentially just wipe out a huge chunk of the T cell population, quite indiscriminately.
Which explains why they're saved for high-risk induction or severe rejection.
Exactly. Or for rejection that isn't responding to high-dose steroids. But this profound effect comes with a consequence. The lymphopenia, the low lymphocyte count, can last for a very long time, months, sometimes well over a year.
And that massive systemic effect must carry risks during the infusion itself.
It absolutely does. This is a major clinical point. There's a very high risk of severe infusion-related reactions.
What kind of reactions?
Things like chills, high fever, shaking rigors, sometimes even shortness of breath or pulmonary edema. It's thought to be caused by the massive destruction of lymphocytes releasing a flood of cytokines, sometimes called a cytokine release syndrome or cytokine storm.
Do you have to prepare the patient?
Mandatory. It's absolutely required that the infusion is preceded by rigorous premedication. Usually a cocktail of corticosteroids, acetaminophen for fever, and antihistamines like diphenhydramine. This helps to dampen that acute inflammatory response during the infusion.
Okay, so that's the broad polyclonal approach. Now, let's contrast that with a very targeted monoclonal antibody used often in induction. Besiliximab, Similect.
Right, besiliximab, we mentioned it's chimeric. Its mechanism is purely signal 3 blockade. Very specific.
How does it block signal 3?
It binds specifically to one part of the high-affinity IL-2 receptor, the alpha chain, also known as CD25. By binding there, it physically prevents IL-2 from docking onto the receptor.
So no signal 3 gets through.
No signal 3, no message to proliferate, but the key difference from AT-JAM is its tolerability, which stems from the fact that it is non-depleting.
It doesn't kill the T cells.
No, it just blocks the receptor site. It's a clean interruption of communication. This is why it's often favored for induction in lower-risk patients. You get that initial suppression of the proliferative burst without the systemic risks, the infusion reactions, the prolonged depletion associated with agents like AT-JAM. It helps bridge the patient safely until the maintenance drugs, like the CNIs, kick in.
But sometimes you do want maximal broad depletion. Is there a monoclonal option for that?
Yes, for really profound depletion, we sometimes use alemtuzumab, AMPATH.
Humanized,
yes. Alemtuzumab represents sort of the modern extreme of lymphocyte depletion. It targets a different molecule, the CD52 antigen.
And where is CD52 found?
That's the key. It's expressed very broadly, not just on T cells, but also on B cells, monocytes, macrophages.
So it hits multiple immune cell types.
Exactly. Binding of alemtuzumab to CD52 causes rapid and profound depletion of both T cell and B cell lines.
That sounds incredibly potent.
It is. Because of its potency, its use is generally reserved for specific, very high-risk induction protocols, or sometimes for treating severe acute rejection, especially if there's an antibody-mediated component alongside the cellular rejection.
And like AT-JAM, that deep depletion must have long-term consequences.
Definitely. The immunosuppression is very long-lasting. T cells might take 6 to 12 months or even longer to fully recover their numbers.
Which means a high risk of infection.
A very high risk. It absolutely necessitates strict, prolonged prophylaxis protocols against opportunistic infections, particularly things like pneumocystis jirovecii pneumonia, PJP, and various herpes viruses like CMV and herpes simplex. That prophylaxis might need to continue for many months after the alemtuzumab dose.
Okay, we've talked a lot about T cells, but B cells, the antibody producers, are also critical, especially in certain types of rejection and autoimmunity.
Absolutely. Humoral immunity, mediated by B cells and antibodies, is a huge factor. And that brings us to rituximab by rituximab.
Chimeric again.
Chimeric, yes. Rituximab is really key for addressing that B cell arm. It targets the CD20 antigen.
And where is CD20 found?
CD20 is expressed on B cells during several stages of their development: pre-B cells, mature B cells, and memory B cells. When rituximab binds to CD20, it triggers B cell depletion, often through complement-dependent cytotoxicity and antibody-dependent cell-mediated cytotoxicity. It basically eliminates a large portion of the B cell pool,
Reducing future antibody production.
Exactly. But here's a really critical clinical point, a nuance you have to understand about rituximab.
Okay.
It spares the existing mature plasma cells.
The antibody factories themselves.
The factories themselves. Because as B cells terminally differentiate into plasma cells, they lose the CD20 antigen from their surface.
Ah, so rituximab can't target them.
Correct. This is why its main uses in transplant are things like desensitization protocols to remove memory B cells before transplant, helping manage ABO-incompatible transplants, and contributing to the treatment of antibody-mediated rejection, AMR, by stopping the production of new antibody-producing cells, but it doesn't eliminate the currently active plasma cells.
Okay, so that's the plasma cell problem in AMR.
Yeah.
If rituximab spares the active factories, and those factories are churning out the destructive antibodies causing the rejection right now, how do you stop them?
That's where you need a different mechanism. You need something that can target and kill those long-lived plasma cells. And for that, we actually borrow a drug from the world of oncology, specifically multiple myeloma treatment.
Which drug is that?
Bortezomib, Velcade. It's a proteasome inhibitor.
How does that work on plasma cells?
Plasma cells, because they are such high-volume protein factories, making antibodies, are exquisitely sensitive to disruption of their protein-handling machinery. The proteasome is critical for degrading misfolded or excess proteins. By inhibiting the proteasome, bortezomib causes a buildup of toxic proteins within the plasma cell, leading to cell cycle arrest and triggering apoptosis.
So it kills the antibody factory directly.
Exactly. It directly decreases the levels of those damaging antibodies being produced. Its use is quite specific for treating established AMR.
We also need to touch on a product that seems ubiquitous, intravenous immunoglobulin, IVG. You see it used in autoimmunity, in transplant desensitization, and in AMR treatment. What's the deal with IVG?
IVG is fascinating. It's a pooled product derived from the plasma of thousands of healthy donors, so it contains a very broad spectrum of normal human antibodies.
So it's like replacement antibodies.
At low doses, yes, it can be used for simple antibody replacement in immunodeficiency, but at the high doses used for immunomodulation in autoimmunity and transplant.
It does more.
Much more. Its mechanism is complex and probably multifaceted. It's thought to induce apoptosis in some B cells, modulate B cell signaling, interfere with damaging autoantibodies binding to their targets, and even inhibit the complement cascade, which is a major driver of antibody-mediated damage.
So it kind of throws a wrench into multiple parts of the harmful immune response.
That's a good way to put it. It has broad immunomodulatory effects. Because it's derived from human plasma, there's always a very low but real theoretical risk of transmitting infections, although screening is rigorous. And the high doses needed for immunomodulation can sometimes cause issues like fluid overload, headache, aseptic meningitis, or even rare but serious problems like acute kidney injury or thrombosis. But its long half-life, around 3 to 4 weeks, gives sustained action.
And before we leave the antibodies, we absolutely have to circle back to the safety warnings. Rituximab, you mentioned, has a particularly serious one.
Yes, this is critical knowledge for anyone prescribing or monitoring it. Rituximab carries a severe FDA-boxed warning regarding the risk of progressive multifocal leukoencephalopathy, PML.
What is PML?
It's a rare but often fatal viral infection of the brain caused by the reactivation of the JC virus, a polyoma virus that many people carry latently. Deep immunosuppression, like that caused by rituximab, can allow this virus to reactivate and destroy brain tissue.
Devastating.
Absolutely. There's also a boxed warning for the risk of hepatitis B virus reactivation in patients who are chronic carriers. So thorough screening for both JC virus exposure, though testing is complex, and hepatitis B status is essential before starting rituximab, and sometimes antiviral prophylaxis is needed.
It really underscores that even these highly targeted therapies have potentially life-threatening downsides.
There's no free lunch in immunosuppression, ever.
Okay, let's shift gears now. We're moving from that initial high-potency induction or rejection treatment phase into the long game.
The marathon, not the sprint.
Exactly. The foundational maintenance agents. These are the drugs patients often take for years, even life, to provide that quiet, steady suppression while, hopefully, minimizing chronic damage.
And the absolute cornerstone of maintenance therapy for decades now has been class 1, the calcineurin inhibitors, or CNIs.
Represented by the two main players, cyclosporine and tacrolimus.
Those are the big ones. They are still, in many ways, the main engine of immunosuppression in solid organ transplant, and they work by blocking the consequences of signal 1.
Let's nail down that mechanism again. We talked about signal 1 triggering intracellular cascades. How do CNIs actually interrupt that?
Okay, it's a really elegant, though complex molecular process. Remember, signal 1, the TCR binding, leads to an increase in calcium inside the T cell.
Right.
That calcium surge activates a specific enzyme, a protein phosphatase called calcineurin.
Okay.
Calcineurin's main job in this context is to remove phosphate groups from another protein, a transcription factor called NFAT that stands for nuclear factor of activated T cells.
Dephosphorylation?
Exactly. When NFAT is dephosphorylated by calcineurin, it's basically given a passport to travel from the cytoplasm into the cell nucleus.
Where the DNA is.
Where the DNA is. Once inside the nucleus, NFAT binds to specific promoter regions on the DNA and switches on the transcription of key genes needed for the immune response. Most importantly, the gene for IL-2.
The signal 3 cytokine.
Precisely. So calcineurin activation leads to NFAT activation, which leads to IL-2 production.
So where do the drugs come in?
The CNIs intervene by stopping calcineurin from doing its job. They don't directly bind to calcineurin itself, interestingly. They first bind to specific intracellular receptor proteins, forming a complex.
Different receptors for each drug?
Yes. Cyclosporine binds to a protein called cyclophilin. Tacrolimus binds to a different protein called FK binding protein, or FKBP.
Okay.
It's the resulting drug protein complex, cyclosporine cyclophilin, or tacrolimus FKBP, that then physically binds to and inhibits calcineurin.
So calcineurin can't dephosphorylate NFAT.
Exactly. NFAT stays phosphorylated, stays stuck in the cytoplasm, can't get into the nucleus, and therefore no IL-2 gene transcription. Signal 3 is effectively silenced before it even begins, even though the block is technically downstream of signal 1.
Now, in practice today, tacrolimus seems to be preferred over cyclosporine much of the time. Why is tacrolimus generally considered the mainstay CNI now?
There are a couple of reasons, but the main one comes down to efficacy. Multiple large clinical trials have consistently shown that tacrolimus-based regimens are associated with a lower rate of acute rejection episodes compared to cyclosporine-based regimens.
So it's just better at preventing rejection?
Generally, yes. Slightly more potent on a milligram for milligram basis as well. However, and this is the huge caveat, their primary, shared, and dose-limiting toxicity is the same. Severe nephrotoxicity.
Damage to the kidneys.
Yes. They both cause constriction of the blood vessels going into the kidney glomerulus acutely, and over the long term, they can cause chronic structural damage, fibrosis, and atrophy in the kidney tubules. It's a slow, insidious damage to the very organ we're often trying to protect.
And this issue of toxicity versus efficacy brings us right back to the nightmare of dosing these drugs, the pharmacokinetics. Why is that routine drug level monitoring absolutely mandatory?
It's all about variability. The way individuals absorb and metabolize these drugs varies enormously. This leads to that dangerously narrow therapeutic window we talked about.
What causes the variability?
A lot of it has to do with metabolism in the liver and absorption in the gut. Both tacrolimus and cyclosporine are extensively metabolized by the cytochrome P450-3A4 enzyme system, CYP3A4, in the liver.
Okay.
And they are also substrates for an efflux pump in the intestinal wall called P-glycoprotein, or PGP, which actively pumps the drug back out into the gut lumen, reducing absorption.
So genetics, food, other drugs.
All of it can dramatically affect CYP3A4 and PGP activity. A standard dose that's perfect for one patient might be dangerously toxic in another, or completely subtherapeutic in a third.
Hence the need for blood tests.
Hence the absolute necessity for frequent monitoring of drug levels, specifically 12-hour trough levels, the lowest concentration right before the next dose. This is the clinical reality, the burden of using CNIs effectively and safely.
Let's illustrate that. Say a patient is stable on their tacrolimus dose, their levels are good, then they get a fungal infection and start taking, say, ketoconazole, a common antifungal. What happens?
It's a classic, potentially dangerous interaction. Ketoconazole, like many azyl antifungals, is a potent inhibitor of CYP3A4.
It slows down the metabolism.
Drastically. So the enzyme that normally clears tacrolimus from the body is blocked. The tacrolimus levels will rapidly skyrocket, potentially reaching toxic concentrations very quickly.
Leading to
Acute nephrotoxicity, maybe severe tremors or headaches, which are signs of neurotoxicity. It's an emergency. Conversely, if they start taking something that induces CYP3A4, like the antibiotic rifampin, or even the herbal supplement St. John's wort,
the levels would drop.
Exactly. The tacrolimus gets cleared much faster, the trough level plummets, and the patient is suddenly at high risk for acute rejection because they're effectively under immunosuppressed. Managing these interactions is a huge part of transplant pharmacy and medicine. Even grapefruit juice is a famous CYP3A4 inhibitor.
Beyond the big one, nephrotoxicity, what are the other side effects that really distinguish cyclosporine from tacrolimus and drive clinical decisions?
They have distinct profiles. Cyclosporine is quite notorious for causing cosmetic issues that can be really bothersome for patients. Specifically, hirsutism, excessive hair growth, often on the face and body, and also gingival hyperplasia, which is overgrowth of the gum tissue.
Which tacrolimus doesn't cause as much.
Much less so. Tacrolimus, on the other hand, tends to be more associated with neurotoxicity, things like hand tremors, headaches, sometimes paresthesias, and it also has a higher propensity to cause or worsen post-transplant diabetes mellitus, PTDM.
Ah, the blood sugar issue.
Yes. So a classic clinical scenario is a patient on cyclosporine who is really bothered by the hirsutism. Switching them over to tacrolimus can resolve that specific cosmetic concern while maintaining effective CNI immunosuppression. It's a common switch.
Okay, so the CNIs are effective, the workhorses, but that nephrotoxicity is just this unavoidable dark cloud hanging over them long term.
It really is the Achilles heel.
Which, understandably, drove the field to look for ways to get similar T-cell dampening without hammering the kidneys.
Exactly. And that search led directly to class 2, the costimulation blockers. Primarily the drug belatacept, NULOJ.
The signal 2 blocker.
The signal 2 blocker. Belatacept represents a fundamentally different approach. It's a clever piece of bioengineering, a recombinant fusion protein.
What's it made of?
It essentially takes the binding part of a natural inhibitory molecule called CTLA-4, which normally helps turn T cells off, and fuses it to part of an antibody structure to make it last longer in the body.
And how does it block signal 2?
Remember, signal 2 requires CD80 and CD86 on the APC binding to CD28 on the T cell. Belatacept acts like a decoy. It has a much higher affinity for CD80 and CD86 than CD28 does. So belatacept binds tightly to CD86 on the APC.
Preventing CD28 from docking.
Precisely. It physically gets in the way, preventing that crucial second signal. Without signal 2, the T cell doesn't get fully activated. It may even become anergic. It's a very clean, targeted inhibition of co-stimulation.
So, given that it spares the kidneys, which is a huge advantage, why hasn't belatacept just completely replaced the CNIs? It sounds like a game changer.
It is a game changer for many patients, especially in kidney transplant, offering better long-term graft function. But it has a major limitation, a critical safety concern.
Which is?
Belatacept significantly increases the risk of developing post-transplant lymphoproliferative disease, PTLD.
A type of lymphoma, a cancer?
Essentially, yes, a malignancy of lymphoid cells that can arise after transplant due to immunosuppression. And importantly, the PTLD seen with belatacept seems to have a higher predilection for occurring in the central nervous system, which is particularly dangerous.
Why does belatacept increase this risk?
The risk is strongly linked to the patient's status regarding the Epstein-Barr virus, EBV, the virus that causes mono. PTLD is very often driven by EBV reactivation in immunosuppressed individuals. If a patient has never been exposed to EBV before transplant, meaning they are EBV seronegative, they lack the baseline immunity to control the virus if they get infected for the first time, or if latent virus reactivates under the influence of belatacept's specific type of immune modulation.
So the risk is highest in those who haven't had EBV before.
Dramatically higher. Because of this, belatacept carries an absolute contraindication. It must not be used in transplant recipients who are EBV seronegative.
You have to test them first.
Absolutely mandatory. Before even considering belatacept, clinicians must check the patient's EBV serology, their antibody titers, to confirm prior exposure. This critical safety requirement, unfortunately, limits its use to only EBV-positive patients, preventing it from being a universal CNI replacement, despite its significant renal benefits. It's also an IV infusion, usually monthly for maintenance, which is different from the oral CNIs.
Okay, moving on to class 3, the mTOR inhibitors. These also target signal 3, but downstream from IL-2 binding. We're talking about sirolimus, also known as rapamycin, and everolimus.
Right. These drugs interfere directly with the T cell proliferation machinery activated by signal 3.
How do they do that?
Remember we said IL-2 binding activates the mTOR protein. mTOR acts like a central processing unit, integrating signals and controlling cell growth, metabolism, and proliferation.
Okay.
Sirolimus and everolimus work by inhibiting this mTOR protein. Like the CNIs, they first bind to an intracellular protein. In this case, it's the same FKBP that tacrolimus binds to.
Oh, interesting.
Yes, but the sirolimus FKBP or everolimus FKBP complex doesn't inhibit calcineurin. Instead, this complex binds to and inhibits mTOR.
Blocking its function.
Blocking its function.
Yeah.
By inhibiting mTOR, these drugs effectively halt the progression of the T cell through the cell cycle, causing it to arrest in the G1 phase before DNA replication can begin. This prevents that massive clonal expansion.
So why use these instead of, or in addition to, CNIs?
The main rationale is often CNI minimization. Because mTOR inhibitors don't have the same direct nephrotoxicity as CNIs, they are frequently used in maintenance protocols to allow clinicians to significantly reduce the dose of tacrolimus or cyclosporine, thereby hoping to lessen the long-term kidney damage.
A kidney-sparing strategy.
Primarily, yes. Or sometimes they are used if a patient simply cannot tolerate CNIs at all. However, the mTOR inhibitors are definitely not without their own problems. They come with a distinct set of challenging toxicities.
Like what?
Well, firstly, like the CNIs, they are also metabolized by CYP3A4 and are substrates for P-glycoprotein, so they have many of the same drug interaction issues and also require therapeutic trough monitoring.
Okay, so same monitoring hassle.
Same monitoring hassle. But their unique side effect profile is what really stands out. They are particularly known for causing or significantly worsening hyperlipidemia.
High cholesterol and triglycerides.
Yes, often requiring treatment with statins or other lipid-lowering agents. They also quite commonly cause stomatitis, which is painful mouth ulcers. And perhaps most critically, especially in the early post-transplant period, they significantly impair wound healing.
How?
The mTOR pathway is involved in normal cell growth and repair processes. Inhibiting it slows down the healing of surgical incisions. Because of this, mTOR inhibitors are generally considered contraindicated or at least need to be used with extreme caution in the immediate weeks to months following surgery.
So you wait until the wound is fully healed.
Typically, yes. They're usually not initiated until at least a few months post-transplant, once the primary healing is complete. Using them too early risks wound dehiscence or infection.
All right, finally, let's cover the broad-spectrum inhibitors, Class 4, the antiproliferatives. These seem to work by directly stopping the building blocks for new cells.
Exactly. They interfere with the synthesis of nucleic acids, DNA, and RNA, which is absolutely essential for any cell to divide.
And the main player here now is mycophenolate.
Yes, mycophenolate, which comes as either mycophenolate mofetil, MMF Cellcept, or mycophenolic acid, MPA, Myfortic, is the current standard antiproliferative agent. It's become a cornerstone of most maintenance regimens alongside a CNI and sometimes steroids.
How does it work? It sounds quite targeted.
It is surprisingly targeted, actually. It's a potent and, importantly, reversible inhibitor of a key enzyme called inosine monophosphate dehydrogenase, IMPDH.
Okay, what does IMPDH do?
IMPDH is essential for the de novo pathway of purine synthesis. Purines, like guanine, are essential building blocks for DNA and RNA. Specifically, IMPDH is needed to make guanosine monophosphate, or GMP.
Right.
Now, here's the clever part. Most cells in the body have a salvage pathway they can use to recycle purines. But lymphocytes, both T cells and B cells, are uniquely dependent on this de novo pathway for their supply of guanine when they need to proliferate rapidly.
So blocking IMPDH hits lymphocytes harder.
Much harder. By inhibiting IMPDH, mycophenolate effectively starves rapidly dividing T and B cells of the guanine nucleotides they need to replicate their DNA, thus halting their proliferation. It's highly effective.
And doesn't need monitoring.
Generally, no. That's a significant advantage over CNIs and mTOR inhibitors. Mycophenolate does not require routine therapeutic drug monitoring. Dosing is usually based on standard weight or fixed doses, though sometimes adjusted for side effects like GI upset or low white blood cell counts.
Well, what about its predecessor, azathioprine? It's still around sometimes. We need to remember that critical drug interaction.
Right, azathioprine, Imuran, is the older antiproliferative. It's largely been replaced by mycophenolate because mycophenolate generally has a better efficacy and safety profile.
How did azathioprine work?
It's a prodrug. It gets converted in the body to 6-mercaptopurine, 6-MP, which is then further metabolized into thioguanine nucleotides. These fraudulent nucleotides get incorporated into DNA and RNA, ultimately blocking chain elongation and cell division.
Less specific than mycophenolate.
Less specific, yes. Its main dose-limiting toxicity is bone marrow suppression, low white cells, red cells, platelets. And the absolutely critical interaction you mentioned is with allopurinol.
The gout medication.
The gout medication. Allopurinol works by inhibiting an enzyme called xanthine oxidase. The problem is xanthine oxidase is also one of the main enzymes responsible for breaking down and inactivating the metabolites of azathioprine, specifically 6-MP.
So allopurinol blocks its breakdown.
Exactly. If you give a patient on a standard dose of azathioprine allopurinol, you block the clearance pathway. The toxic metabolites of azathioprine accumulate to dangerously high levels, leading to profound, potentially life-threatening bone marrow suppression.
So you have to cut the azathioprine dose way down.
Dramatically, usually by about 75% if allopurinol must be used concurrently. It's a classic, potentially fatal drug interaction that everyone needs to know.
And we can't wrap up maintenance without revisiting the old guard, the foundation of immunosuppression for so long. Corticosteroids.
Absolutely. Drugs like prednisone or methylprednisolone, despite efforts to minimize them, they remain a ubiquitous part of many maintenance regimens and are still first-line therapy for treating acute rejection episodes.
What's their mechanism? It seems very broad.
It is very broad and very powerful. Steroids work by binding to glucocorticoid receptors inside cells. This drug receptor complex then moves into the nucleus and directly alters the transcription of hundreds of genes, particularly those involved in inflammation and immune responses.
Turning inflammation down.
Turning inflammation down, yes. But they also have direct effects on immune cells. They rapidly reduce the number of circulating lymphocytes, especially T lymphocytes, partly through lysis, killing them, and partly by causing them to redistribute out of the bloodstream and into lymphoid tissues. T cells are particularly sensitive.
So very effective, but the side effects.
The side effects are legendary and legion, especially with long-term use. They are diabetogenic, raise blood sugar, cause hypercholesterolemia, lead to severe osteoporosis and fractures, cause hypertension, cataracts, skin thinning, muscle wasting, mood disturbances, weight gain, Cushingoid appearance. The list is incredibly long.
Which is why everyone wants to get patients off them if possible.
Exactly. It's this profound systemic toxicity profile that drives the major clinical push towards steroid minimization or complete steroid withdrawal protocols in the long-term maintenance phase whenever it's deemed safe enough for the patient's rejection risk.
Okay, let's try to bring this all together. If we synthesize this whole pharmacological strategy, modern transplantation maintenance is really defined by this layered approach, right? Strategically interrupting the T-cell activation cascade at multiple points.
That's the core concept. You block the consequences of signal 1, primarily with the CNIs.
You might block signal 2 itself with belatacept if the patient is EBV positive.
Right. You can block the proliferation driven by signal 3 using mTOR inhibitors, often to spare CNI dose.
And then you add broad suppression of cell division using an antiproliferative like mycophenolate and maybe low-dose steroids.
It's multi-targeted blockade. Now, for someone aiming for that elite professional level of understanding, moving beyond just knowing the drug classes, it really comes down to mastering the nuances, the matrix of monitoring requirements, specific toxicities, and key contraindications. That's what translates knowledge into safe and effective clinical practice.
Okay, let's crystallize those key takeaways. First, drug monitoring. Which ones absolutely need those trough levels checked?
Mandatory 12-hour trough monitoring for the CNIs, tacrolimus and cyclosporine, and also mandatory for the mTOR inhibitors, sirolimus and everolimus. Why? Because of that narrow therapeutic index and that highly variable CYP3A4 metabolism and PGP transport.
And which ones generally don't need routine troughs?
Generally, no routine trough monitoring needed for mycophenolate, basiliximab, used for induction, or belatacept. Their dosing is more standardized, or levels don't correlate as well with efficacy or toxicity in the same way.
Second, let's hammer home those critical drug toxicity links, the ones you absolutely have to associate.
Okay. CNIs, tacrolimus, cyclosporine, think nephrotoxicity first and foremost. That's the big one.
Got it.
But also remember the specific cosmetic issue. Cyclosporine, hirsutism, and gingival hyperplasia.
Right.
mTOR inhibitors, sirolimus, everolimus, think hyperlipidemia and critically impaired wound healing. Also, stomatitis.
Okay.
Belatacept, the absolute contraindication is EBV seronegativity due to the unacceptable PTLD risk.
Crucial.
And rituximab, remember those black box warnings for PML and hepatitis B reactivation? These aren't just lists. These are the immediate dangers associated with using these powerful tools.
Third, let's quickly revisit the antibody choice for induction. Polyclonal versus monoclonal strategy.
It comes down to potency versus tolerability, driven by the mechanism. Polyclonal antibodies like ATGM thymoglobulin are potent T-cell depleters, used for high-risk induction or treating severe rejection. Because they cause mast cell lysis, they demand mandatory premedication to manage those severe infusion reactions. In contrast, targeted monoclonal antibodies like basiliximab are non-depleting IL-2 receptor blockers, used for lower risk induction, often as part of CNI-sparing protocols. Much better tolerated, require no premedication because they don't cause that widespread cell destruction.
Finally, let's put it into a crisis scenario. A patient had a kidney transplant 3 months ago. They've been stable on their maintenance meds, say tacrolimus, mycophenolate, and low-dose prednisone. They come into the clinic, their creatinine level has shot up dramatically. Biopsy confirms severe acute cellular rejection. What's the go-to most effective intervention right now?
In that scenario, just increasing the doses of their current maintenance drugs, like tacrolimus or mycophenolate, is almost never enough to reverse severe, established acute rejection.
Need something stronger.
You need an immediate, powerful reset of the attacking immune system. The most effective therapy for severe acute rejection remains a potent, lymphocyte-depleting antibody treatment.
Like ADGM.
Exactly, like rabbit antithymocyte globulin, thymoglobulin. You need to quickly eliminate the large number of activated T cells that are currently infiltrating and damaging the graft. You need to effectively wipe the slate clean before trying to reestablish control with maintenance therapy. So if we look back, We've really mapped that entire journey, haven't we? From the very first interaction of a T cell with an antigen,
Through the whole three-signal confirmation process.
right down to the specific molecular nuts and bolts of how these different drug classes, from broad polyclonal antibodies to highly specific fusion proteins, interrupt that cycle at precise points.
It's incredibly sophisticated.
It is. And the real art, the daily challenge in transplantation and increasingly in autoimmunity, lies in that constant balancing act, weighing the intense, immediate risk of the immune system destroying the graft or attacking the body,
Against the severe, chronic, and very drug-specific toxicities of these incredibly powerful agents.
always searching for that sweet spot, that combination and dosage that provides just enough suppression but minimizes the long-term harm.
So, mastering this, what does it really mean for patient care moving forward? It feels like the newer drugs are getting smarter.
They are. The clear trend is towards greater specificity, developing drugs like belatacept, which precisely targets signal 2 to avoid the systemic damage of CNIs, or like mycophenolate, which cleverly exploits that unique metabolic dependency of lymphocytes.
It gets us closer to the goal. Protect the organ or calm the autoimmunity, but without the widespread collateral damage we saw with older, less selective therapies like high-dose steroids or azathioprine.
It's about refining the intervention, making it more targeted, more intelligent. And maybe a final thought to leave you with, consider the broader implications of this toolkit we've built. We mentioned sirolimus, right, an mTOR inhibitor designed to stop T-cell proliferation.
Yeah.
Well, outside of transplant, sirolimus and its analog everolimus are coded onto drug-eluting stents used in cardiology.
To prevent arteries from reclogging after angioplasty.
Exactly. Its antiproliferative property, honed to stop immune cells, is repurposed to prevent the smooth muscle cells in the artery wall from overgrowing and causing restenosis. Same drug, same fundamental mechanism inhibiting proliferation via mTOR, but used in a completely different clinical context.
Yeah.
So the provocative thought is this. If a drug designed to manipulate the immune system can be adapted to treat heart disease, and similar pathways are relevant in cancer, what other seemingly unrelated fields, maybe neurodegeneration, maybe fibrosis, maybe even aging, might eventually benefit from repurposing or adapting the sophisticated tools we've developed for targeted cellular manipulation and signaling interruption in immunology? That cross-disciplinary application of deep molecular knowledge, that's where some really exciting frontiers in medicine might lie.